It's so good to see all of these faces. I'm Anissa Mitchell with PMD Alliance. I'm glad you're with us today. We're going to be having a conversation with Dr. Gregory Pontone. We're going to be talking about anxiety and behavioral disturbances in Parkinson's disease. This is actually the second in a series because he was with us, I don't know, what was it, a month ago? Was it last month? Time seems to be very elastic. And we talked about depression and apathy and all of those things. So today we're going to be focusing more on the anxiety aspects of mood issues. And so I'm excited to invite Dr. Pontone back. So Dr. Pontone is an associate professor in the Department of Psychiatry at Johns Hopkins University School of Medicine, and he's the director of their Parkinson's disease neuropsychiatric clinic, where they focus on diagnosing and treating the neuropsychiatric aspects of Parkinson's and related disorders. So we're excited to have him. And please feel free to put your questions in the chat as we go along today. We're going to hold those until the end, but we'll try to get to as many of them as possible. And I'm going to pass this over to Dr. Pontone. Thanks for being a part of this conversation again.
Hello, thanks for having me today. I'm going to go ahead and share my screen. Hopefully this works. There you go. You should see it now, and then I'll make it full screen. Today, I'd like to talk to you about anxiety and some of the behavioral changes that can happen in Parkinson's disease. I don't have any relevant financial relationships with commercial interests pertaining to the content of this talk. I will say that by the end of today, I hope that you'll be a little more familiar with how anxiety might present in Parkinson's disease. And we'll talk a little bit about things called impulse control disorder, punding, and I'll give you definitions for all these things. We'll talk about how the biological aspects of Parkinson's might be associated with the experience of anxiety and some of these behavioral disturbances that we're going to talk about. And then we'll review the best evidence treatments for both the anxiety and behavioral disturbances in Parkinson's. Now, let me give you an overview of anxiety in Parkinson's because it can present in many different ways. So at least half of people with Parkinson's will have clinically significant symptoms. Now, some people will have so many symptoms that it's called a disorder. So, you know, when you have a runny nose and a cough and congestion and body aches, you might have the flu. That's a syndrome. And so in the same way, you know, if you feel tense, you know, your muscles are sort of tight and you're worrying and your stomach has butterflies and your heart's palpitating, that could represent an anxiety disorder. Whereas just worrying or one symptom isn't a syndrome. Now, that said, about a third of people with Parkinson's at some point in the disease, and some even before they know they have the disease, will have an anxiety disorder. At least 40% of people with Parkinson's rank anxiety as one of the top 3 unmet needs in Parkinson's. And so this is a big target for people with Parkinson's disease. And when we look at its overall impact on quality of life in Parkinson's disease, it probably has a larger impact on quality of life than even the motor symptoms that, you know, we diagnose the disease with. And so what is anxiety going to look like in Parkinson's? Well, there is the typical anxiety that you could see in anyone that can be diagnosed, you know, at any time in life, called generalized anxiety disorder. And this is sort of a keyed up state where people are apprehensive and worried and tense all the time for no particular reason. Sometimes that anxiety can even interfere with sleep or concentration. About 14% of the time, that's what it looks like in Parkinson's. It's just what we call generalized free-floating anxiety. Now, another big one in Parkinson's is what we call social phobia. And so this is a fear of talking or speaking in public. And I don't necessarily mean in front of a crowd. This could be anxiety even with just a handful of people. Some people are actually afraid to eat in front of others, especially when the motor symptoms make them a little more clumsy. Using the restroom in front of others can be a sign of a social phobia. So basically, this starts to limit or cause them to avoid their opportunities to be social, which then creates an entirely different problem of social isolation, which we've shown can have negative health outcomes as well. And so that's probably the two most common types of anxiety that we see in Parkinson's. Some people might have panic disorder. Now, this one is interesting because it's not with you all the time necessarily. It's having episodes of extreme anxiety that occur and maybe only last 10 to 20 minutes. But during that time, you can't think, you can't function. Many people think they're dying. People end up in the emergency room when they have this. And then after the episode's over, they don't necessarily feel anxious. However, some people develop a fear of having another panic attack, and that can become limiting as well, because if they had one in public, they might be afraid of being out in certain situations for fear of having another attack. And so those are the ones that most people have heard of because they happen in people with Parkinson's and they happen in people without Parkinson's. But then within Parkinson's, there are a couple of different manifestations of anxiety that might be specific to the disease. And so right now, when we classify these, we call these anxiety disorders not otherwise specified. And they're things like fluctuating anxiety attacks that occur during off episodes of your Parkinson's medication. So as they wear off, you might experience anxiety. A type of anticipatory anxiety that's a little bit like generalized anxiety, where you worry or ruminate about upcoming events, even mundane events like going to the store or going to a doctor's appointment, even if you'd seen the doctor for 10 visits before. We'll talk a little bit about that type of anxiety, but we think this type of anxiety might be associated with the biology of the Parkinson's disease itself and might need special treatments, treatments that would not necessarily be found in non-Parkinson's populations. Now, the other interesting thing is at least a third of people who have an anxiety disorder have two or more. So when people are anxious, sometimes it's more than one. They might have panic attacks and a social phobia together. And so anxiety can be a pretty significant problem. Now, here's something that's interesting. Let me orient you to this figure. Remember when I said anxiety disorders can occur at any time in the person with Parkinson's life? That means once they have the disease or even before they knew they had the disease. That's what this figure shows. So the horizontal line at the bottom, that's the x-axis. Time 0 is the time when motor symptoms start, and that's when most people are diagnosed with Parkinson's. Everything to the right of that in blue is once you know you have the disease. Everything to the left in red are the years before you even know you have Parkinson's. In those red peaks, sometimes people have anxiety that's associated with a twofold or greater risk of later Parkinson's. And we're not sure exactly what the marker for the anxiety that's predictive of Parkinson's is versus anxiety that's unassociated, but we can certainly say that people with anxiety disorders at large are at increased risk of Parkinson's. And some of this might be due to the early disease process changing the chemistry of their brain and causing certain types of anxiety symptoms. And so let me show you what we found when we looked at this in people with Parkinson's disease. So this is the similar figure to the one I just showed you, with time 0 being the time of motor symptom onset and the time when people are usually diagnosed with Parkinson's. Everything to the left that we've colored gold is before you know you have Parkinson's, and everything in that sort of burnt orange is once you're diagnosed. Now, what's really interesting is, remember, these are people who we interviewed after they knew they had Parkinson's, is we looked at the types of anxiety that occurred in that burnt orange peak compared to the type of anxiety that occurred in that gold peak. And what we found is that in this kind of burnt orange peak, these are people who have 2/3 of them have anxiety associated with the fluctuation or wearing off of their Parkinson's medication, which we think is a Parkinson's specific anxiety experience. So as your medications wear off and your motor symptoms come back, people feel acutely anxious or even panicked sometimes. And that's what we found in that orange peak, whereas the things in the gold peak were the generalized anxiety, panic disorder, and social phobia that you could see in anyone. Now, here's the other interesting thing. In that gold peak, when you look at epidemiologic studies of different populations, this has been replicated now 5 or 6 times in different countries. Anxiety might be a premotor or prodromal symptom of Parkinson's disease before you're even diagnosed. And the reason that we think this is that whether you look at the level of an anxiety disorder, like generalized anxiety, panic, what have you, or as a symptom, just having sort of continuous worry, or as a personality trait, just being highly neurotic. And these are 3 different studies. It conveys an increased risk of Parkinson's. You can see in the top one, if it's a disorder, there's an odds ratio of 2.2 greater odds of Parkinson's up to 20 years before Parkinson's is diagnosed. People who have phobic anxiety symptoms have a 1.5 increased relative risk of Parkinson's later in life, and people with an anxious personality have about a 1.6, 1.5 roughly increased hazard ratio of later Parkinson's. So clearly you can see that there's an association between anxiety and Parkinson's. And the question is it just a risk factor that makes you more vulnerable to having Parkinson's, or is it really early disease before it starts to cause the motor symptoms? And we're not sure. I think it could probably be different in different individuals. But the one thing we're sure about is that this association between anxiety and later Parkinson's has been replicated many times. Now, let's talk about potential mechanisms of anxiety and Parkinson's disease, or things that can be experienced as anxiety, but are actually some sort of biological phenomenon causing you to feel as if you're anxious. And so let me give you an example. Everybody has fight and flight reaction, right? You have that dump of adrenaline when you see a bear or something bad happens, right? Well, this fight or flight is mediated in part by your autonomic nervous system, right? It's a cascade of hormones and chemicals that get you keyed up and ready for action. Okay, so when you're afraid, you're either going to run or you're going to fight, right? And you might do a little of both. Imagine now that you have a disease that sort of causes false alarms, causes a false triggering of this autonomic nervous system. That's what happens to at least 70% of people in Parkinson's disease, at least to some degree. Some people get it more, some people get it less. This can cause excessive sweating and trouble regulating your body temperature. This can cause changes in blood pressure, usually too low, but sometimes too high, hyperventilating, and obviously the trembling, which is sort of a rhythmic oscillation of the musculature. Okay. Now, all of this is, autonomic nervous system dysfunction, but think about it. You're used to feeling this when you're in fight or flight or when you're scared. And so when people have this false alarm from the Parkinson's, subjectively, they experience it as an anxiety attack. Okay. So it's experienced as anxiety, but I guess you could say it's not because you're worried about anything, right? You didn't see a bear, you're not standing on the edge of a cliff, whatever your fear is, right? You're not speaking in front of a crowd. You just have this out of the blue sort of nervous feeling. This has been studied in Parkinson's in a relatively small study of about 32 people. And basically what they found is when they measured these autonomic symptoms and compared them or correlated them to a Hamilton Anxiety Scale, there was a positive correlation, meaning that at least some people who report feeling anxious with Parkinson's might actually be experiencing autonomic dysfunction. And the reason that's important is you can use anti-anxiety medications all you want, and these symptoms aren't going to necessarily improve, right? You're going to keep having them because they're really autonomic nervous system symptoms, not pure anxiety. Okay. Now, it doesn't mean that your anxious response to experiencing these symptoms won't get better. The symptoms won't get better because you're targeting the wrong thing. And so in Parkinson's, this is an important thing to talk about with your doctors. So when you say you're anxious, do your best to describe, is it a physical anxiety? You know, are you tense? Are you sweating? Are you lightheaded? Are you hyperventilating? Anything you can think of that comes along with a subjective sense of anxiety is going to help your doctor better target these symptoms. Okay. Now, there's another type of anxiety that we think is somewhat specific to Parkinson's, and we call it anticipatory anxiety. And this is anxiety in anticipation of an upcoming event. And now look, people who have generalized anxiety and don't have Parkinson's have some of this as well, but it's really conspicuous in Parkinson's. And I can tell you that I see it in at least a third of the people I work with Parkinson's disease. And to me, it seems like when they think of their day, let's say they have a trip coming up and they have to travel from point A to point B, maybe there's a flight. As they go through the sequence of events, they can't allay their anxiety by going through the sequence, right? They just keep getting more and more anxious and they start catastrophizing. You know, what's the worst that can happen? Instead of saying, oh, if I have to use the restroom, I know where they are. They're usually by, you know, the security desk or whatever. Instead, as they go through, it just ramps up the anxiety. And I've had people who stay up the night before an event, even though it's not a big deal event. The event itself isn't scary. And to us, that sounds like it could be associated with the executive cognitive dysfunction that happens in Parkinson's, because that sort of changes your ability to organize, sequence, and plan. And so for this type of anxiety, sometimes we'll have people with a caregiver or spouse or family member talk through the event a little bit, you know, in a very deliberate way to sort of help them go through their list of things and hopefully bring down their anxiety. And it's been studied, and although it didn't necessarily land on the executive dysfunction as we sort of hypothesized, turns out that people with Parkinson's who also have mild cognitive impairment are more likely to have this type of anxiety than the non-anxious. Okay. And so clearly there's the change of cognition is what's causing people to have this type of anxiety. So again, the reason I'm bringing this up is you're experiencing it as worry and anxiety, but it's really caused by a change in your cognitive abilities. So you could target the anxiety all you want. It'd be like treating pneumonia by suppressing the cough, right? You're not really targeting the cognitive change. You're treating the end outcome, right? You really want to treat the pneumonia, you want to treat the infection in the lungs, and the cough will go away. Treating the cough won't make the infection go away. Same thing here. And so that's why I think a lot of times people go to their doctors to get their anxiety addressed when they have Parkinson's, and they give them all the best medications that are available on the market, and they don't work, or they partially work because the symptom is really coming from another biological place. Okay. And then one more example of this idea of the cause being something separate than the anxiety itself. This is back to that figure I showed you. And this is the anxiety that's associated in the burn orange peak with the wearing off of carbidopa, levodopa, or dopamine medications. So what's happening is people feel the dopamine leaving their body near the end of dose, okay? Their symptoms start to come back. So if they have tremor, the tremors reemerge. If they have stiffness, they feel tight and stiff and tense, right? And they're slowing down. Sometimes maybe they even freeze. That would scare anybody, right? So they start to associate the return of symptoms and the loss of dopamine, which is also an important chemical for feeling good, with distress and anxiety. Okay. And like I said, this we think is a type of anxiety experienced by people with Parkinson's that doesn't necessarily happen to people who don't have Parkinson's and aren't taking these medications. So another important thing to consider is if you have anxiety and you have Parkinson's, you also want to talk to your doctors about whether or not there's an association between the timing of your anxiety and the timing of your Parkinson medication dosing. So if you notice, hey, every 3 or 4 hours or so, near the end of dose, I'm getting anxious and keyed up, there might be an association with the medication. But if you didn't document it, you just say, I don't know, I feel like I'm anxious 4 or 5 times a day, and that doesn't really help you or your doctor solve the problem. So, if you can, when you document, if you have episodic anxiety, try to do it within the framework of the timing of your medication dosing, because that can be very helpful in discerning whether or not it's related to the on-off fluctuation in your response. Now, just to kind of put this a little more concretely, everybody's interval is a little bit different. Some people take medications every 5 hours, some people every 4, some people every 3, and occasionally every 2. So you really have to understand your schedule. And then sometimes you might start at 9, or if you sleep in, you might start at 9:30. If you wake up early, you might start at 7. So each day it might move a little depending on the timing of your dose too. And so just keep that in mind, that it's relative to when you take the dose and then when you experience the anxiety, okay? Now, just to show you how concretely this has been established, when people had this idea that anxiety was potentially triggered or caused by the reduction in dopamine, maybe near the end of dose, they said, well, what about if we infuse the dopamine right into the veins? So this study did just that. They had a dopamine, a levodopa infusion into the veins. And what they found is, as the dopamine infusion started, people's anxiety went down. It was relieved. And then when they stopped the infusion, which is the end of that gray box, anxiety went whoop, right back up. Anxiety spiked again. So this sort of proved the concept that the change in dopamine was enough to trigger anxiety episodes in people with Parkinson's disease. So this is something that we're confident does and can happen just because of the changes in dopamine. Now, I will tell you that I've seen people who, even when they're off, they stay calm. So again, to me, that's a hopeful message, because it means if we can teach people some skills, even if they're experiencing these off episodes, they can handle them a little bit better rather than panicking, okay? There's also maybe ways to bridge the dopamine with your neurologist to just avoid the off episode completely. But sometimes if you can't completely avoid it, there are definitely ways to cope with it. Now, the other type of anxiety that it's not, 100% specific to Parkinson's. I mean, I've seen people who fall for other reasons or also have a fear of falling, but fear of falling is a big deal in Parkinson's. And let me tell you, most of the time, it's a very rational fear, right? I mean, once you've had a fall with an injury, it's a significant concern. And, falling is probably the first or second biggest risk in Parkinson's in terms of your overall longevity and health, right? Because complications of falls are what cause a lot of trouble for people with Parkinson's. And so this has been studied a lot. There's been at least 22 studies that have looked specifically at the fear of falling in Parkinson's and how it changes behavior. And there was, across these 22 studies, over 1,000 patients with Parkinson's disease who experienced these fear of falling in at least half of them, okay? Now, people who had this fear, even if you control for age and duration of disease, having the fear of falling was associated with more frequent freezing of gait, more turn hesitation, slower speed of walking or gait, and greater balance problems, or what we call greater postural impairment, okay? So having the fear actually worsened the physical symptoms that already existed. Solving the fear improved these physical symptoms. So if you've ever been afraid of doing something, especially if you're afraid of heights, all of a sudden it seems like walking is harder. If you're on a ledge, all of a sudden you should be able to walk, but seeing the ground beneath you makes you sort of less capable of maintaining your balance. The same thing happens when you have this fear. And so it's an important symptom to A, recognize, and B, treat, because it slows you down. And if you can better handle that fear, you function better, okay? So hopefully what I've done here is showed you two things across these examples. Is one, sometimes the biology of Parkinson's or the condition of Parkinson's creates anxiety or triggers anxiety in a way that can be solved by acting directly on the Parkinson's or by learning to cope with the problems that the anxiety causes, okay? Now, let's talk about some of the treatments more specifically. So the Movement Disorder Society, that's what that MDS stands for, had a task force that looked at the best evidence medicine for treating anxiety in Parkinson's disease across many publications and papers and studies. And what they found, unfortunately, is that the evidence to support or refute specific treatments is insufficient. And that means that we need to do more research. And so the evidence that does exist is usually secondary outcomes. So for instance, maybe they were studying a drug to see how it treated depression and Parkinson's, but they happened to ask a few questions about anxiety. That's called a secondary outcome. And it's only partial information, but that's the best we have. And so what I'm going to be discussing is really from studies where anxiety was a secondary outcome, okay? And so what's happening hopefully here in the future is that we're studying anxiety with more primary intention, okay? One of the things that we are already confident of, and hopefully from the examples I showed you, is that optimizing your motor function and addressing any on-off fluctuations in your medication is likely an important thing for controlling anxiety and Parkinson's disease, because on-off fluctuations in your medications, dose failures, fear of falling, all of these things can trigger anxiety, okay? And then once the anxiety is there, the cat's out of the bag. So they have done, as of this presentation, one randomized placebo-controlled study to treat anxiety and Parkinson's. It was a very small, really sort of almost proof of concept study, meaning that it wasn't powered to give a definitive answer. The medication that they were studying is called buspirone or Buspar. It's a medication that's used sort of 2 to 3 times per day to control anxiety. It was only 21 people, and they were randomized so that 4 to 1, for every one person on a placebo, 4 would get the buspirone. So that's to increase the signal of the drug. And they looked at the Hamilton Anxiety Scale, which is a validated anxiety scale in Parkinson's. And what they found is that there was a little bit of improvement on the scale, but it wasn't necessarily significant. So that NS means not statistically significant. So even though the anxiety moved in the right direction, meaning reduced, there was 3.9 and 7.1, depending on the scale. The PAS is a Parkinson Anxiety Scale. It wasn't significant. So they couldn't tell whether that was due to chance or the actual action of the drug, okay? Tolerability, though, was an issue. And so with this buspirone in Parkinson's, more than half of the people on it felt like their motor symptoms got worse. In fact, about 40% didn't even complete the study because they found the drug wasn't tolerable. And so this drug, I think it was a great idea to study, right? You have to start looking at a medication, and this is the one they chose. But this does not look like an effective treatment. Some people still take it. Another trial, again, it was phase 2, which is an early phase of testing. Usually this is a testing for safety, tolerability, and dose finding, is Nabilone. Nabilone is sort of it's in the cannabinoid family. So it's tetrahydrocannabinol. So, from the marijuana plant. It was open label, which means that everybody was on the substance, right? And then what they did is that some people at the end of the first part of the study were either switched to placebo or some were continued on the drug randomly, okay? Now, there was also some side effects. So 77% had side effects. We call that AEs, which is adverse events. during the open label titration, but they were not serious. They were usually things that people could tolerate. And again, it looks like that this compound might lower anxiety and help with sleep. Again, it's an early phase trial, and it's recent, so it was just released in the Annals of Neurology in 2020, so about 2 years ago. And so if there's momentum here, you could see this get more intensive testing in Parkinson's, and it might become one of the first evidence-based treatments for anxiety, but there's still a long way and probably several years to go before we'll know with certainty whether or not this is going to be effective compound. Now, I'll talk about some of the medications that are already on the market for anxiety in a few minutes and about how efficacious they might be. But one of the things that we're confident will help, and it's a non-medication therapy, is called cognitive behavioral therapy, okay, for anxiety and Parkinson's. And 2 groups have done some pretty sophisticated studies of cognitive behavioral therapy for anxiety and Parkinson's. And what they found is that regardless of the type of anxiety you have, this therapy can be helpful. Now, cognitive behavioral therapy is a very sort of structured therapy that usually requires multiple sessions, anywhere from 10 to 20 sessions to be helpful. But it's something that can be done in conjunction with medications or by itself. And what I would say personally is, if you have anxiety, this is as good a place to start as any, because it has very few side effects other than the time it takes to attend. Now, another thing that they're very interested in is mindfulness-based therapies. And so these are sometimes combined with yoga or meditation, but mindfulness-based therapies, there hasn't been a lot of study, but there's some emerging evidence that these could be very useful, and they actually overlap a lot with what happens in cognitive behavioral therapy. They sort of teach you to separate your emotional response from your thoughts, okay, and behaviors. And so again, stay tuned, because I think you're going to hear a lot more about mindfulness and meditation-based strategies. Exercise seems to help depression and anxiety, if for no other reason, by diffusing the physical tension you experience in a distressed state. So exercise is still king. It helps with the movement aspects of Parkinson's, helps with cognition, and it helps with anxiety and depression. And then an emerging option, and I think this is another thing that you'll hear a lot more about, is neuromodulation. Now, whether this is invasive or non-invasive, it seems to be helpful, and it's just a matter now of finding out which modality might be helpful. So Rtms, which is a type of repetitive transcranial magnetic stimulation, is one that's helpful. Transcranial direct current stimulation, that's the TDCS. That's something my group is looking at right now. It's where we actually run live current through the head externally. And then deep brain stimulation are all promising modalities for improving anxiety. Now, again, these are studies that have mostly been secondary outcome, right? Where the actual study was done for another reason, and then anxiety questions just happened to be attached to the study. So again, I think as we go forward, a more deliberate study will tell us whether or not these types of brain stimulation will have utility. Now, let me give you some more granular detail on this cognitive behavioral therapy so you can get a sense, because this really, of all the things that I've talked about so far, is the one that we have the highest confidence and the most evidence for being helpful. As you can see here, this was 10 weekly sessions. So remember, I said 10 to 20 sessions is usually the range. They compared this to clinical monitoring only, and this is where it gets interesting. So, you know, when they had the control group, which would usually in a drug study get placebo, when you're giving therapy, you have to do something that approximates the placebo in a medication study. So they had these people just come in to be clinically monitored. So you'd ask them questions about their anxiety, you know, check in on them, but you wouldn't give them CBT. And the outcomes were that Hamilton Anxiety Rating Scale, which is one of the best scales for anxiety and Parkinson's, along with the Parkinson's Anxiety Rating Scale. And what they found, and this is really interesting, is that when you did CBT, not only was it helpful during the time they were receiving the CBT, when they called them back up 3 and 6 months later, there was still a significant reduction in anxiety from undergoing the cognitive behavioral therapy. So even though, the skills that you learn in the therapy are sort of portable, meaning that as long as you remember them and maybe practice some of the techniques, they're still reducing your anxiety 3 and 6 months out, okay? And then I've seen many people who do refresher modules of cognitive behavioral therapy after the case. Now, the other really interesting thing here is that clinical monitoring only, there was a reduction in anxiety. So sometimes there's a reassurance just in seeing the doctor. And so, what we always say is sometimes when you have anxious Parkinson's patients, even if they're not getting CBT, seeing them a little more frequently might help. And certainly this study tells that story. Now, here's another specific study about the mindfulness that I mentioned to you, combined in this case with yoga, compared to, because remember, we always need a control group or a placebo group. And in this case, if we have one group doing mindfulness along with yoga, we thought, well, when we bring the other group in, if we're not going to do mindfulness with them, what are we going to do? So we did stretching and resistance training, okay? And so this was a pretty big study. So this is usually you're better powered for statistical significance with a big study. And so there's 138 individuals matched 1-to-1 with yoga versus stretching and resistance training. So, that's weights or bands resistance for 8 weeks. And just like I told you before, exercise is king. So whether it's yoga or stretching and resistance, everybody's movement got better, okay? So that equally efficacious for Unified Parkinson's Disease Rating Scale for Part 3, that's movement. So everybody's movement got better, whether you were in the yoga group or the stretching and resistance group, you got a little better in terms of your movement. But it turns out that the yoga combined with the mindfulness was superior to just stretching and resistance training for anxiety and depressive symptoms. And so something about focusing your mind deliberately on something other than your distressed emotional state seems to lower anxiety and depression. And so this is what I meant about the hopefulness we have for mindfulness and other meditative therapies, okay? Because what they're really teaching you to do is to find a place in your head where you're less worried about these emotional responses that are sort of raining on you. And that's really what cognitive behavioral therapy is teaching you as well. It's, you have these automatic thoughts of catastrophe, and you're learning to reframe those in a more hopeful way. Now, this is a slide that Dr. Kelly Mills and I put together to guide doctors who treat Parkinson's in terms of the use of the existing therapeutics for anxiety, okay? Now, let me just briefly walk you through this, because this is something that your doctors are going to mostly do and guide you through. But when somebody has anxiety that is biologically based, whether it's generalized anxiety, panic disorder, something like that in the population, whether they have Parkinson's or not, the first line treatments are antidepressants, okay? And there's different types of antidepressants. There's selective serotonin reuptake inhibitors, there's selective norepinephrine reuptake inhibitors, there's tricyclics that do a little of both of those chemicals plus some dopamine. The point is antidepressants, believe it or not, are usually the first line therapy for anxiety disorders in the general population. And in Parkinson's, there's no reason to think that most types of anxiety, the ones that aren't related directly to dopamine or fear of falling, would also improve in Parkinson's from these antidepressants. And so I think for most people who experience anxiety and Parkinson's, it's worth trying antidepressants as a first-line treatment, either combined with, cognitive behavioral or mindfulness therapies that we discussed, okay? And then do you see that behavioral activation / exercise? We think everybody should be doing that with anxiety, okay? And so some people, it might just be the behavioral activation exercise and CBT, or it might be exercise and an antidepressant medication, or it might be a combination of all three. And then we have a scenario where if they don't respond, they would use a combination of medications or medications and therapy. And that's really what this slide is showing you. But the reason I put it up here, even though it's aimed at doctors and other providers who prescribe these medications, is so that you know that we have a very elaborate protocol for addressing anxiety and Parkinson's. And even if you don't get improvement after the first couple things you try, we have many, many things to try. And, you know, I think we can be very hopeful that most people can experience improvement in their anxiety, okay? And so now I want to transition, just for the last 20 minutes or so, to these other behavioral disturbances that can happen in Parkinson's disease. And so these are chiefly what we call impulse control disorders, and punding and dopamine dysregulation. So I'm going to go through and describe these to you. Very often they fly under the radar. And part of the reason that they're unrecognized or underappreciated is because they're things that all of us do. It's just that in the case of impulse control disorders, for instance, they are done excessively or in a way that leads to bad outcomes or risk, okay? So let's start with these impulse control disorders. And they're really an assortment of behaviors. And I'm going to give you a few examples, but let me tell you, there could be 20 different ways you could have an impulse control disorder. I'm going to give you 4 or 5 of the most common, okay? They're performed repetitively, excessively, and importantly, with a lack of self-control, and to an extent where it interferes with daily functioning, okay? In Parkinson's specifically, it has definitely been associated with dopamine agonist medications. These are things like pramipexole, which goes under the brand name Mirapex, and ropinirole, which goes under the brand name Requip, much less, but sometimes with Nupro, which is rotigotine patch, okay? And then it has been associated with high doses of carbidopa-levodopa, okay? So dopamine clearly plays a role in this. In fact, we think that at least 15%, maybe more, of people who are on dopamine agonists will experience these impulse control disorders. Now, what are the most common ones we see in Parkinson's? Pathological gambling. I mean, I've seen people lose their retirement savings, their kids', you know, college savings. This is gambling that sometimes might have predated Parkinson's. You know, maybe I was just a casual gambler and it got much worse once I had Parkinson's and got on dopamine medications. Clearly, you know, the dopamine fueling the worsening of the behavior. Sometimes people will have problematic gambling that continues through, and occasionally we'll find people who were never gamblers who pick it up after Parkinson's. That's a clear red flag, and you know, you want to take a look at the medications and talk to your neurologist. Compulsive buying and shopping. I'll give you an example. This isn't just, you know, having a little bit of a shopping spree because it's 2 a.m. on Amazon. This is a guy who has a 2-bedroom condo who bought 15 Art Deco lamps, you know, more lamps than he has rooms in his house. And so it's really sort of undirected by need or even reason, okay? Clearly out of control. Hypersexual behaviors. Remember, most of the people who suffer from Parkinson's are, you know, 60 and up. The majority of people are 60 and up. And so for both men and women, you know, even the most robust of us, the drive kind of drops off. But I've seen 70-year-old men with hypersexual behaviors that would rival anything I've seen in an 18-year-old boy. And so it's clearly, as one of my colleagues, Zoltan Mari, says, extra physiologic, fueled by the dopamine, driven in a way that's beyond the normal appetites that people have. And I've seen a lot of bad outcomes, relationships and marriages disrupted by this. And again, if you see a new sexual behavior that's problematic, be suspicious of the medications, especially if there's a dopamine agonist. And then binge eating. This is eating beyond what's required for the hunger, and even beyond what most emotional eating might be, you know, just boxes and boxes of things, sometimes to the point of vomiting. Now, along with this impulse control disorder, occasionally what you'll see is a cluster of behaviors when people are on high levels of dopamine. People start to feel almost a reward almost an intoxication from the extra dopamine. And they'll start to take more and more dopamine, even more than the neurologist prescribes. Now, fortunately, this doesn't happen often. It's just, 2-3% of people with Parkinson's, but you can become almost addicted to the dopamine, getting a euphoria from higher than necessary doses. And it's more often found in men and people who have early onset Parkinson's. And in that population, if you take out the women and you just look at young onset men, it's as many as 3 to 4% of them. And by the time they're taking all that dopamine, you're going to see oftentimes a lot of dyskinesia, a lot of impulse control disorder. They're going to have a higher likelihood of hallucinating or being psychotic. And they may even have panic attacks because essentially what they're doing is they're getting too revved up from the dopamine. So if you see a scenario where people are running out of their dopamine, their Parkinson's medications before their next visit, just keep that in the back of your mind. It doesn't happen often, but when it does, it can be really problematic. And then this is one I want to describe, this behavior called punding that I want to describe. It's sort of a repetitive, purposeless behavior that's sort of an intense preoccupation with specific items or activities. So you might rearrange your kitchen, every few days, but then when you look at it, there's really no rhyme or reason. You're just moving things back and forth, or fold and unfold things, or pick at little pieces of fabric or something. So it's this repetitive, kind of semi-purposeless behavior. Okay. Sometimes I've seen people who do this in their hobbies or occupations, so repetitively do things. And again, it's driven in part by dopamine. So we see this more often on higher levels of dopamine, or in periods when people feel a little confused or disoriented. They'll sort of start a behavior, but then before they complete it, they just repeat parts of it in a, like I said, semi-purposeless way. And so it's been described in people who abuse amphetamines or speed, where they'll, get intoxicated with the amphetamine, and then they'll take things apart, right? And then as they slow down, they stop fiddling with things. Well, in the same way, it might be that dopamine is revving people up and they start punding and manipulating things. And as they come down, they don't. So oftentimes when you see punding, you might see it in a sort of episodic way throughout the day. So a lot of the punding that I hear of from the people I work with Parkinson's occurs in one of two scenarios. It can happen anytime, but most often it occurs in the late afternoon when people are sort of tired near the end of the day, or in the late evening after dose stacking throughout the day, where maybe they're on their 4th or 5th interval of dopamine medications, and now it's built up and they're punding at night. Okay. And I've even seen it with phones and tablets, where people they'll play games, and then next thing you know, it's 3 a.m. and they're still up playing the game and they don't know why, So I just want to throw that out there in case you see a behavior that's sort of repeated and you can't really tell why, but it's clearly getting out of hand. And then let's just talk briefly, and then I'll take some questions about the treatments for these behaviors. So for impulse control disorders, dopamine dysregulation syndrome, where you're taking too much, and punding, sometimes reduction or withdrawal of the dopamine agonist is the first place to start. Okay. And you'd say, well, geez, if I take away my dopamine agonist, how am I going to move? Oftentimes the levodopa is less likely to trigger or cause these behaviors. So you can replace the agonist with an equivalent amount of levodopa. Okay. And this helps about 1/3 of the time. Okay. Now, the problem is, coming off dopamine agonists, many people experience withdrawal from coming off of them. So this can be a slow process, and you'll have to monitor the impulsive behaviors while you're going down. In the same way that we talked about, there's been very few controlled trials to treat anxiety. There's been very few trials to treat impulse control disorders. They've tried amantadine, which is usually used for dyskinesia, to see if it would help with impulse control. And they tried a drug that's used sometimes in opiate abuse, naltrexone, and they really didn't have a clear positive signal. So neither one is clearly efficacious, but they've been tried. Again, cognitive behavioral therapy that we talked about was good for anxiety and depression. Looks like there's been at least one small early study. Cognitive behavioral therapy might help with some aspects of the impulse control disorder. And then for pathological gambling and some of the hypersexual behaviors, we found that using the addiction model, with 12-step groups, which first, cause the people to identify as having the problem, which makes them accountable, and then having the sort of peer monitoring and acceptance of the 12-step process can be helpful. So certainly I can tell you at our center at Hopkins, all of our pathological gamblers, we encourage to join, Gamblers Anonymous. And believe it or not, there's 12-step groups for sex problems. And so those two behaviors do well in a group setting. Almost always involving the caregiver and family is important, because people tend to either have diminished insight about how problematic these behaviors are, or they're ashamed. And so they sort of tend to minimize the problem. And so having caregivers and family can give you a sort of more neutral perspective on the extent of the behaviors. And so, again, this is the current guidance, and hopefully in the future, there'll be more controlled trials. And then finally, the one thing that I want to throw out there, and this happens usually in more advanced disease, is when people are experiencing anxiety or these behaviors and their cognitive status has changed, as maybe some people with the disease become more impaired, it can just look like distress or even acting out, okay? And so you don't necessarily, sometimes doctors will just reach for a medication that will sedate people who are distressed or acting out, when really you should be trying to see if they're anxious or depressed and just can't articulate it, okay? And so I put this slide in here just to say that sometimes it's important to really dig, ask questions, involve family members and caregivers to better understand the resulting behavior, so that you're not just, using a hammer, a blunt force to address something that could be done in a more gentle way. Okay. And then I will tell you, though, that if you have distress and you're having trouble determining if it's distress from anxiety, from depression, or from some other cause, CBT and mindfulness might not work when people's cognitive status is limited, right? So if people are having more memory problems, those sort of lose their utility. But people have experimented now with music therapy, other ways to sort of change the environment so that it's less stimulating when people are distressed or agitated, and that can tend to minimize or decrease these behaviors or anxiety. And then activity therapy. So sometimes providing structured activity can also be a way to divert attention from the distress, okay? And so I just want to put this out there that, when you've tried everything else and nothing seems to work, sometimes these other therapies might at least reduce the severity of some of the symptoms. And then I'll stop there and see if there's any questions about any of the things I talked about so far today.
Awesome. Thank you so much. Actually, you were talking earlier about triggers, and someone mentioned that multitasking is an anxiety trigger for them. So is there something cognitively that could be going on that could create that anxiety from that multitasking?
Absolutely. So that's a great point. So the model that we have for that anticipatory anxiety is that it's caused by executive dysfunction. And so when you're multitasking, the demands on your central, the speed of central processing are greater than you can accommodate with Parkinson's, especially because that seems to slow down processing speed. That's one of the universal changes, just like it slows down the body. And so what we found is that people who focus on one task at a time tend to have less anxiety and to function better. So that is a great point.
Now, on the other side of that, this person said, I find that stress causes them to run out of gas, meaning they burn through their carbidopa levodopa faster. Can you speak to that?
Yeah, so this has been looked at not just in Parkinson's, but in anxiety and non-Parkinson's populations. And anytime stress is high, there's what's called gating theory. So when you're directing your body to do something, but it's distracted by an emotional experience like fear or anxiety or worry, it drains the amount of energy you can put toward focusing on the task. So it sort of is like that multitasking, right? You're trying to pay attention to the fear and anxiety while doing something, and it's exhausting, right? It's like running energy through two channels instead of just one. And so oftentimes what we find is that when you turn down the anxiety, which is like fight and flight, your energy is better directed. You'll have more energy for the task at hand.
So you were talking about different drugs that have been tried on people to see if they were efficacious. And there was somebody who said that they had done a study on ketamine, and while they were getting infusions, they felt really good, and a lot of their physical issues disappeared. Do you know much about the ketamine, and is it applicable to this situation in this population?
Yeah. So first of all, what I will say is that most of the ketamine studies have been done in non-Parkinson's populations, and they've made big news in the last couple of years. And they appear to be not only efficacious for anxiety and depression, but rapidly efficacious. And one of the reasons we think that happens is when you give ketamine, there's a certain receptor in the brain that ketamine binds to very tightly. It's what we call high affinity, right? And antidepressants bind to the same receptor, but they bind it much, much less tightly, okay? And so antidepressants to treat anxiety take 4 to 8 weeks to work. Ketamine works within hours or days. And so we think it's the difference in how tightly they bind this receptor. So I guess in a very long-winded way, what I'm saying is ketamine has absolutely been shown to be effective for anxiety and depression, but not specifically in Parkinson's. There's no reason to think that it won't be effective in Parkinson's, but we haven't tested it specifically there. And the reason that it appears to be somewhat more efficacious and certainly more rapidly efficacious is we think has to do with the more tight binding of this receptor. And so again, I think the hope is that you'll hear a lot more of this treatment going forward in the future. Now, that said, ketamine is also a dissociative anesthetic. So it's been used in medicine for a long time to treat pediatric burns, because it sort of allows the poor child who's suffering from the burn to be dissociated from the trauma of the experience while, the debriding and treatment of the burn wound is happening. So that opens up some of the side effects that could be problematic in Parkinson's. So confusion and risk of falls is probably going to be elevated with ketamine treatment, but it's done under supervised conditions. But I think that's a great point too. That's something that I think you'll hear about more coming up.
And I'm also curious, because you talked about there being adverse events with Nabilone, with it being a synthetic cannabinoid. So we didn't really talk about this, but what is your thoughts about THC or CBD?
Yeah, so this is, I have to tell you, this is another one. Michael Pollan is an author who writes a lot about plant-based therapies and psychedelic therapies. And it turns out that Johns Hopkins has one of the biggest and longest tenured studies on these type of compounds, cannabinoids, hallucinogens, psychedelics, whatever you want to call them. And so we've got a long history of studying these compounds. And the first thing I would say about cannabinoids, THC, all these compounds is the brain has a ton of cannabinoid receptors. And so, whether these are synthetic, like the one you mentioned that I quoted the study from, or the ones from nature, the potential is there. What's lacking is the study within Parkinson's and for these symptoms. And so what I always tell people is it's hard to recommend them because we don't know what variety or what dose or how long for these symptoms. But again, it's a area of active interest. And I think, safety is always first for me, and I think it should be for everybody else. So as long as it's safe, I think some experimentation is reasonable. I always tell people though, confusion and, being a little wobbly from high doses of anything is a risk in Parkinson's.
And one last question, because we are running out of time and I want to protect your time, is someone asked, what type of depression and anxiety tends to work better, or what medication, SSRIs or SNRIs?
So that's a great question. So in non-Parkinson's populations where these have been tested, SSRIs seem to have a greater efficacy on average. And so these are your things like sertraline, which is Zoloft, your Prozac, your paroxetine, your Lexapro, your I'm trying to think of the next one, Celexa. So there's a bunch of them, and they seem to work a little better for anxiety than the SNRI. So that's a great question.
Awesome. Well, this has been a fantastic overview, and I learned a lot today. I'm sure everyone learned a lot today. So I really appreciate your very well-rounded overview of this topic. And I'm sure that we didn't get to all of the questions, but we had some good ones. I think a lot of them, though, you kind of preemptively answered as you were going through your presentation. So I want to thank you. And I know we did this before, but we have a tradition at PMD Alliance as a way of thanking our wonderful speakers for their time and their expertise. That's our wave of gratitude. And everyone on my screen currently has already put their video up. So I see everyone's faces. So hopefully you can too. So I'm going to invite everybody to give you the wave of gratitude. And thank you so much for this great presentation. And I want to thank everyone for joining us today. And it is recorded. The slides will be available. So give it about 24 hours or so, and it should be up on the website, and you'll be able to access that. And, you know, you may need to go back and listen to some of it again because it was full of great information. So thank you so much, Dr. Pontone.
Thanks for having me. Take care.
Thank you, everyone.